Welcome to The Explainer. Today we're going to build the definitive clinical guide for managing herpes simplex virus type 1. We're covering everything, from the very first time a patient presents all the way to long-term prevention. Think of this as your complete framework for a really common but sometimes tricky virus.
Okay, let's just dive right in with a scenario that you will 100% see in your training. A patient walks in with what looks like a classic case of primary gingivostomatitis. They're in a lot of pain, they're worried, and they're looking at you for answers. So, what are the critical decisions you need to make in that moment?
To build that perfect plan, we're going to break it down into these 5 parts. First, we'll look at the drugs themselves, our toolkit. Then we'll walk through the big clinical scenarios you'll face. And we'll wrap up with proactive care and how to talk to your patients about all this.
So, first things first, let's get really comfortable with our main tools of the trade. Nailing the fundamentals of these antiviral agents is the foundation for everything else we're going to talk about.
Before you even think about writing a prescription, your whole approach really hinges on the answers to these 3 questions. Is this their first rodeo, or is this a recurrence? How sick are they? Is it just a little cold sore, or are they so miserable they can't even swallow? And finally, is the infection just in the mouth, or has it gone somewhere else?
Now this is where things get interesting. You can really see the evolution of these drugs here. Acyclovir is the original, the one with the most data. But look at valacyclovir and famciclovir. They're what we call prodrugs. That just means they get converted into their active form inside the body, which gives them way better bioavailability. And what does that mean for your patient? Less frequent dosing. And that is a huge win for making sure people actually take their medicine.
Okay, so let's get back to our first clinical challenge, managing that initial or primary HSV-1 infection. Just like that patient from our opening question.
This is the million-dollar question, isn't it? For any illness that's eventually going to get better on its own, you have to ask, is it actually worth treating? When a patient is feeling absolutely awful with their first outbreak, you need to know if the medicine you're prescribing is going to make a real difference.
And boom, here's your answer. The data could not be clearer. In a really important study, starting oral acyclovir early didn't just help a little bit. It slashed the median duration of lesions from a miserable 10 days all the way down to just 4. I mean, that is a massive, clinically significant impact on someone's life.
So the bottom line is you've got to act fast. That 72-hour window is key to getting the best result with one of these oral regimens. Now, if you have a patient who is so sick they have severe odinophagia, that's intense pain with swallowing, and they just can't get pills down or stay hydrated, that's your red flag. That's when you need to think about admission for IV acyclovir.
Okay, we've handled the first episode, but as we all know, HSV-1 is the virus that keeps on giving because it establishes latency. So now, let's dig into the problem you'll see way more often, managing those recurrent oral herpes outbreaks, what most people call cold sores.
With recurrent disease, there is no one-size-fits-all answer. It's really a conversation with your patient, and you're guiding them toward one of these 3 paths. For some people, honestly, the best option is no antiviral treatment at all. For others, it's about either treating each outbreak as it pops up or taking a daily pill to stop them from happening in the first place.
This slide is your roadmap for that conversation. Think of it like this. Episodic therapy is reactive. The patient feels that classic tingle, the prodrome, and they jump on a short course of high-dose antivirals to knock it down. Suppressive therapy, on the other hand, is proactive. This is for your patients who get frequent, really severe, or just emotionally devastating outbreaks, and they want to prevent them from ever even starting.
So what's the real benefit of episodic therapy? Well, the data shows it can shorten an outbreak by about 1 to 2 days. Now, that might not sound like a lot, but you ask anyone with a painful, visible lesion on their lip, getting rid of it 2 days sooner is a pretty big deal. The absolute key, though, is that the patient has to have that prescription ready and start the moment they feel that prodrome coming on.
Okay, we've spent a lot of time talking about the mouth, since that's its most common hiding place. But HSV-1 can show up in other places, and it is crucial to recognize these other presentations. They can range from just an annoyance to a true emergency.
All right, first up, herpetic whitlow. This is an HSV infection on the finger. It often happens when a patient touches an active cold sore and then touches a cut on their finger. The management pearl here is simple. Don't overthink it. You treat it with the same oral antiviral game plan as you would for a primary oral infection.
Now, on the complete opposite end of the spectrum, you have disseminated disease. This is pretty rare in people with healthy immune systems, but it can show up as really serious stuff like herpes hepatitis. This is a don't-miss diagnosis. It's a true medical emergency, and your high index of suspicion followed by getting IV acyclovir started immediately is absolutely critical.
All right, let's bring it all home with the final piece of our framework, getting ahead of the problem. How do we help patients prevent recurrences? And, just as importantly, how do we counsel them to prevent spreading the infection to others?
For some patients, their triggers are super predictable. Sunlight exposure is a classic one. For them, the evidence is solid. Advise them to use sunscreen. It really works. Then you have certain high-risk procedures, like facial surgeries that mess with the trigeminal nerve area. In those cases, the data supports giving prophylactic antivirals to prevent a reactivation.
And finally, our job is not done until we've educated the patient. These 3 points are non-negotiable parts of the conversation. Number 1, avoid intimate contact and sharing things like utensils during an active outbreak. 2, they have to understand that oral HSV-1 is a major cause of new genital herpes infections. And that leads to number 3. Recommend barriers like condoms for oral sex to protect uninfected partners.
And one last thing. For those patients on long-term daily therapy, this is a super important reminder. This is not a set-it-and-forget-it prescription. People's recurrence frequency can change over time, so it's just good practice to check in at least once a year and have a chat about whether continuing the daily meds still makes sense for them.
So, there you have it. That's your complete framework for managing HSV-1 with the tools we have today. But you know, science never stands still. There are entirely new classes of drugs in development, which raises the ultimate question. Could we one day move beyond just suppressing the virus to actually curing it? It's an incredible thought, and it could totally change how we approach this infection in the future.